What I'm going to cover is the epidemiology of atrial fibrillation and then talk about ways to prevent stroke from atrial fibrillation. AF is a big problem because it can result in death, stroke, an increased number of hospitalizations, a decrease in quality of life, and a decrease in the function of the left ventricle. This is a pandemic type of disease. The incidence has increased 13% over the past 20 years, and tens of millions will be affected by year 2050. Increasingly, we're realizing that obesity and older age are risk factors that help explain the rise in incidence of atrial fibrillation. You can see as we age, the prevalence of atrial fibrillation increases with each decade of life, and men actually are more prone to have atrial fibrillation than women at any age group. In the Framingham Heart Study, we see not only does the prevalence of atrial fibrillation increase with age, as shown in the orange bars, but the number of strokes, the proportion of strokes attributable to atrial fibrillation also increases with age. So by the time we get to be octogenarians, 20% of strokes are attributable to atrial fibrillation. It's a major public health threat. How do we assess the risk of an individual's likelihood to get a stroke? What's best known is the CHADS index, and it's a score. CHADS is an acronym for congestive heart failure, hypertension, age greater than 75 years, diabetes, and stroke. And the C, H, A, and D each get 1 point, and having suffered a stroke or a transient ischemic attack gets 2 points. Generally speaking, if you have a CHADS score of 2 or more, you're at moderate to high risk of stroke from atrial fibrillation and should be on an anticoagulant blood thinner. Here you see with each increase in score point in the CHADS index, and you can have a maximum of 6 points, there's an increase in the percentage of strokes per year. And by the time you get to a stroke rate of 4% per year, the risks of a stroke are so high that anticoagulation is definitely warranted. And there is some discussion about even starting to prescribe anticoagulants for those with a bit lower risk. To really expand at the low-risk end of the system, in Europe and in the Heart Rhythm Society, which is a society that focuses on atrial fibrillation, a new scoring system has come into being called the CHADS-VASc index. It includes the CHADS score, but it adds a point for vascular disease, such as myocardial infarction, peripheral arterial disease, or aortic plaque. It adds 1 point for being age 65 to 74 and ups the point score to 2 points for age greater than 75. And for the sex category of female, adds a point. So certainly if you have, now the thought is if you have 2 or more points in the CHADS-VASc index, you should be on an anticoagulant blood thinner. And then how do you assess the risk of bleeding if you are started on an anticoagulant? There is this another new index called the HAS-BLED index, which can semi-quantify your bleeding index once an anticoagulant has been prescribed. Well, what are our therapies? I'm going to start on the right-hand column where you see aspirin compared with placebo. Aspirin definitely reduces the risk of stroke in patients with atrial fibrillation by about 20, maybe even 25%. And aspirin is something we can buy without a prescription. However, the reason we usually use warfarin rather than aspirin is because a series of studies of stroke prevention in atrial fibrillation were done comparing warfarin with aspirin, and it's clear that warfarin reduced the stroke by another 35% or so lower even than aspirin. So warfarin beats aspirin, and aspirin beats placebo for stroke prevention in atrial fibrillation. Now, if we're using warfarin, it's important that the quality of the anticoagulation be excellent and that the patient on warfarin be maintained on that therapeutic range between 2.0 and 3.0 in the INR, the International Normalized Ratio. If you are at a center where the time within the therapeutic range, the TTR, is less than 65%, this large study of atrial fibrillation patients, called the ACTIVE study, showed that in this case, oral anticoagulation was no more effective than aspirin. So to get that advantage from warfarin or Coumadin in oral anticoagulation, you have to be in the therapeutic range at a center that maintains that INR in range more than 65% of the time. And if you're at one of those high-quality centers, then oral anticoagulation with drugs such as warfarin or Coumadin cuts in half the stroke rate compared with aspirin or aspirin plus another antiplatelet drug, clopidogrel. So if you're on anticoagulation, the quality of the anticoagulation control is of crucial importance. The problems with warfarin include delayed onset and offset of the drug, an unpredictable dose response, a narrow therapeutic index, hundreds of drug-drug and drug-food interactions, problematic monitoring, a high bleeding rate. Even if you're within the targeted INR range between 2.0 and 3.0, you're still at risk of getting bleeding into the brain. And in fact, 40% of all hemorrhages into the brain on warfarin occur among patients who are in the correct INR range between 2.0 and 3.0. Finally, if you want to reverse the warfarin, it takes about 5 or 6 days to have it wash out of the system. Now, the novel oral anticoagulants, there are many, but I want to tell you about the top 4 in the pipeline. There is dabigatran, which is an oral direct thrombin inhibitor. And then there are 3 direct factor 10A inhibitors that you should keep your eye on because there is a lot happening with the development. Rivaroxaban, apixaban, and edoxaban. Now, these new agents have rapid onset, all 4 of them. They are given in a fixed dose. You don't have to adjust the dose like we do with warfarin. And therefore, you don't need to get INRs drawn. You're just given a fixed dose, like most of the medications that we prescribe. Essentially, there are no interactions with food, so you can have as much broccoli or spinach or Brussels sprouts as you want on these novel oral anticoagulants. Very few drug-drug interactions, and the half-life is short. If you want to get rid of the anticoagulant effect, if you wait 10 or 12 hours, it's gone. This is what dabigatran looks like. It's a small molecule. It's inactive until the stomach acid cleaves off this etixylate portion, and then it becomes a potent anticoagulant. History was made in this field. You know, warfarin was introduced in 1954, and from 1954 until October 19, 2010, warfarin was the only available blood thinner in the United States. But on October 19, 2010, the FDA approved dabigatran in a dose of 150 milligrams twice daily for patients with creatinine clearances greater than 30. And for patients with kidney disease, very serious kidney disease, the FDA approved a lower dose of 75 milligrams twice daily for stroke prevention in non-valvular atrial fibrillation. The pivotal study upon which the FDA based its decision is called the RELY trial. And in RELY, this was a huge randomized controlled trial of 18,000 patients, 6,000 of them receiving warfarin, 6,000 of them receiving a dabigatran dose of 110 milligrams, which ended up not being approved, and I'll show you why, and then 6,000 receiving the approved dose of 150 milligrams twice daily. In the dose that was approved by the FDA, dabigatran beat warfarin and reduced the stroke rate 30% more than warfarin, which in turn had reduced the stroke rate 30% more than aspirin, which in turn had reduced the stroke rate 25 to 30% more than placebo. And this difference between dabigatran and warfarin in the dose of 150 milligrams twice daily was highly statistically significant. Warfarin was given in high quality. Patients maintained a time within the therapeutic range overall of 64%, which is pretty good. And dabigatran also in this pivotal trial against warfarin appeared to reduce mortality. There was a 15% reduction in death from vascular causes and a borderline statistically significant 12% reduction in death from any cause. Most of the time in the world of blood thinning, if you have a more effective blood thinner and get fewer strokes or fewer blood clots, you pay the price with more bleeding complications. And usually you have to choose between more bleeding complications and fewer blood clots, or more blood clots and fewer bleeding complications. In terms of bleeding into the brain, which is the most feared bleeding complication of them all, dabigatran not only beat warfarin by having 30% fewer strokes than warfarin, but dabigatran also had a 60% reduction in head bleeds compared with warfarin. And in fact, all of the novel oral anticoagulants, for reasons we don't entirely understand, appear to have a reduction in head bleeding into the brain, compared with warfarin. Now, there are some potential disadvantages with the novel oral anticoagulants. We don't have a specific antidote. We have to wait for tincture of time. And if someone's bleeding, 12 hours can be a very long 12 hours. And then the patients taking these new drugs have to be very compliant and adhere to the drugs as prescribed. Because if they skip or forget a dose of one of these new drugs, there'll be no protection because there won't be any blood thinner in the system. Whereas with warfarin, if you miss one or two doses, generally speaking, you're still protected because the drug takes so long to wear off. There's no laboratory test that's available to monitor the anticoagulant effect of these new oral anticoagulants. They're given in a fixed dose, so if for some reason you wanted to raise the dose or lower it, you really can't do that. And if you only look at the cost of the drug and don't look at anything else, that's called silo budgeting, then the drugs, all of them, appear to be expensive. That changes, of course, if you take into account the cost of caring for a stroke victim or caring for the victim of a head bleed. But the advantages are superior stroke prevention than warfarin in patients with atrial fibrillation, less intracranial bleeding with dabigatran, no more trips to the lab for INRs, minimal drug-drug and drug-food interactions, and because the drug has a short half-life, if a colonoscopy needs to be done or some other surgical procedure, you don't have to do anything. Thanks. You don't have to do anything special. You just skip 2 doses of the drug, and there's no anticoagulant effect. Now, cost effectiveness should take into account the cost of caring long-term for debilitated stroke patients, and it should take into account the cost of caring for an intracranial hemorrhage when a cost-effectiveness analysis is done. We did some back-of-the-envelope calculations comparing the cost of warfarin with dabigatran. Of course, with warfarin, you pay not only for the drug, but you pay for the cost of the laboratory testing of the INRs, and you pay for the pharmacist or the nurse who works in the anticoagulation clinic. Nevertheless, dabigatran still, in terms of drug costs, is about $2 per day more expensive than warfarin. And so the question we have to ask ourselves is it worth spending $730 per year in additional costs to reap the benefits of a 0.5% lower annual mortality, a 0.6% lower annual stroke rate, and a 0.4% lower annual intracranial hemorrhage rate? At our own anticoagulation management service at Brigham and Women's, we find that the costs for nurses, pharmacists, the drug, and the laboratory testing comes to about $1.3 million per year. And the costs of, if we were to switch everybody to dabigatran, the cost of the drug itself would be $4.3 million per year. But this is a classic example of silo budgeting because it does not take into account the whole notion of 20 years in a skilled nursing facility for a stroke victim, or the stroke victim's loss of productivity at work. So I've talked a lot about dabigatran because it's FDA approved. Rivaroxaban has also completed a study against warfarin in what's called the ROCKET AF trial. And rivaroxaban was shown to be non-inferior to warfarin, and it almost was superior in terms of stroke prevention. In fact, if you were to analyze those patients who actually took rivaroxaban compared to those who actually took warfarin, the stroke rate is statistically significantly lower in the rivaroxaban group. So keep your eye on the rivaroxaban ball. Also, a fascinating study was done with another novel oral anticoagulant, apixaban. Apixaban was used against aspirin in patients who were deemed not to be candidates for warfarin because they had had problems with warfarin before, or their doctors thought they were just too high a risk for warfarin. Apixaban performed so much better than aspirin that this study was halted early for ethical reasons because it was preventing so many strokes and cutting the stroke rate in half compared with aspirin alone. Especially fascinating in this AVERROES study of apixaban versus aspirin in patients who were deemed not to be candidates for warfarin was that the bleeding rate, the bleeding complication rate with apixaban was no higher than the bleeding complication rate with aspirin. So imagine having a blood thinner that cuts the stroke rate in half, but yet has a bleeding complication rate no higher than an aspirin tablet. Here I've put together a comparison of these three pivotal trials: RELY with dabigatran, AVERROES with apixaban, and the ROCKET-AF trial with rivaroxaban. They're all mega trials. They were all randomized studies. They all enrolled patients in their 70s. And in all studies, there were more men than women enrolled in the trials. The ROCKET-AF patients with rivaroxaban had the highest risk patients. More than half of them had previous strokes. And because they were the highest risk, they also had the highest CHAD score that I had talked to you about. You'll see in all of these studies that the major bleeding events with warfarin are about 3.5% per year. And the intracranial hemorrhage or intracranial bleeding rate with apixaban is the intracranial bleeding rate with dabigatran and with rivaroxaban is about half that compared with warfarin. So just to put this together, dabigatran was superior to warfarin for preventing stroke in AF patients with less intracranial hemorrhage. Rivaroxaban was non-inferior to warfarin for stroke prevention using an intention to treat statistical analysis, and it was superior to warfarin for those patients who actually took the drug. And like dabigatran, rivaroxaban had less intracranial hemorrhage. And apixaban was better than aspirin, so good in fact that the trial had to be halted after about 5,000 patients were enrolled. At the end of August, the study called Aristotle will be released, where apixaban is compared directly with warfarin. Now, warfarin is still alive, and it's fighting to stay in the game. It's still, until these recent trials came along, had excellent efficacy. It has low cost for the drug itself, not for the complications of the warfarin. It's had a long track record. Anticoagulation clinics are getting to be more and more successful, maintaining the time within the therapeutic range greater than 60%. There's some excitement about using rapid turnaround genetic testing to get better at the initial dosing of warfarin. And a lot of patients have home INR testing machines, and they can do what's called point-of-care testing, which certainly improves the quality of life and gives patients more ownership over warfarin. My take-home points are that the novel oral anticoagulants, though expensive, will provide us with more choices and more convenience. And for dabigatran, 150 milligrams twice daily, more efficacy than warfarin and less intracranial bleeding than warfarin. I do think that warfarin's low price, efficacy, and long track record will prolong its life for a while, and it won't entirely disappear from the scene. Thank you very much.